This is part 3 of the January 5th workshop on the lower limb, and now we're going to start going through all the structures, everything from the skeleton and joints down up out to the muscles.
Okay. The pelvis is a bowl, and it has an anterior, a posterior, and a lateral part. All right. The big bone is all about muscle attachment. Luke is bringing a big bone up here.
Bringing a pelvis and a knee.
All of this is big and flat like that, so lots of muscles can stick on it. Big, hard attachments. And they use that. That's backwards. There's better. All right, they do that so that they can stick this on the torso. All right. This is the sacroiliac joint. It has to move when we walk, but it has to be stable when we stand. The joints of the other bones that are involved with this fuse as adults, but they are mobile as children. And that's why children have a little bit more flexibility. And if they're in a performance thing, like gymnastics or something, because there is slop, there is elasticity in some of these joints, they can do things like the splits and all that kind of stuff. But they are creating hypermobility when they do that. And that will come back to haunt them. Hypermobility is way worse than hypomobility. This thing called the ischial tuberosity is where most of the muscles come in and attach the leg onto this, and then the gluteal muscles also specifically are involved in holding the leg in the ball and socket joint. Once we get past this, now we got a long bone with a ball and socket joint that goes down into a hinge joint, which is the knee. Now it's not totally a hinge joint. It goes back and forth, but it also has a little bit of internal and external rotation. It's a stability joint too, but also a mobility joint. So when the hip joint in the socket is stable, it's a particular position that it's in. So the sacroiliac joint, the hip joint, the knee joint, and the ankle joint all fit together like a puzzle so that we're stable. That's all got to shift when we move. So this balance between stability and mobility is where most of the problems come in. Oh, nice leg.
There we go. Thank you.
Down from that, we have the ankle. We have the ankle.
So now we have the leg with just the bones, and we have the leg with the muscles.
Well, and if you look at here now we've got two bones. This joint over here is built to break, or this bone, the fibula, built to break, not the tibia. You break that, you're in trouble. The two come together and make a saddle, and then your ankle comes into that, and that's just a mess. Look at that. There's a million little joints and joint surfaces and all kinds of stuff in there. Hardly any muscle direct acting on the ankle. Tons of muscles in the foot. Not great stability on the knee. Much better at the hip. So, when we do a general massage, we have to think about all aspects of this. We have to think about the anterior part from joint to joint. So that's posterior. The anterior part, which is primarily the quadriceps of the thigh, are all about knee extension, which is really important. There's minor function at hip flexion. Sartorius can come in there and do that, and quadriceps femoris can do that. Did I say that right?
Yeah.
Well, you never know.
Rectus femoris, technically, but you guys got it.
Yeah, I knew I was wrong.
Okay, so if you think,
Quadriceps femoris is this.
so one quick thing to consider, the most superficial muscles are the only ones that will tend to, if there are any muscle that crosses two joints, most muscles only cross one joint. And every muscle has to cross at least one joint in order to produce movement. But only the very most superficial ones cross two joints. So on the anterior thigh, only sartorius and rectus femoris function at the knee and the hip. That's it. When we get to the posterior side, the hamstrings actually all cross both.
Good job. All right. You see how this is a V right here with tensor fascia lata and sartorius? That's, whenever you see a V like that, you're starting to think they work just like if you were stabilizing a tree that you had planted. And you've got to pull equally on either side, and what's in the middle is going to be stable. So, what can go wrong in the front? Where would a release come in the front? Not much. But there is something that we're going to work on called a firing pattern, which means that these muscle groups, 1, 2, 3, need to contract in a certain pattern so that the patella can slide and the knee can move. So if you were looking for something fancy to do here, other than good pressure, general massage, and getting all three aspects of it, it would be a firing pattern thing, which is in the handouts and we're going to practice. There is not very much on the front part of the leg. This is technically the thigh, and then the leg is below the knee. So don't do much there. Ta-da. All right, lateral, what do we got over here? In the leg, it's the IT band. Right, which is a big piece of duct tape attached to a tarp that you cannot change the texture of. So somebody have come in and say, I need my IT band work done?
Oh, yeah.
Yeah, well, I don't know what to tell you. All right, it is a stability structure from the hip to the knee. It's big. It thins out to wrap the lateral leg, both front and back. It comes up into the glutes, crosses over into the big lumbar dorsal fascia, eventually goes up to the opposite shoulder. So if somebody says they have a tight IT band, don't work on the IT band.
Work on the attachment area.
You work on the muscles that attach into the IT band, because those muscles have a contractile function. So think about, anybody got a trampoline in their backyard or had one? You know why you have to pull tension on the springs on the outside so that the trampoline part itself has got buoyancy or tone to it. If you want that to be stiffer or if you want that to be looser, you don't do anything to the trampoline, you do stuff with the springs. So what attaches into this? Tensor fascia lata, vastus lateralis, gluteus medius, gluteus maximus. You've got portion of the hamstring. It comes down and around and feeds into the lateral side of the leg and goes into some of the stability mechanisms on the gastrocnemius. That's what you apply inhibitory pressure plus movement. And their IT band will feel better. But clients want you to work on their IT band, right? And they want a certain level of sensation, or they're not going to be satisfied. So you can knead it, roll it. You don't want to roll right on it. Bones right under there. There's nerves under there. There's vessels under there. You can stick suction cups on it. Anything that makes them feel like something happened. And your intervention is to bring down the pull force, bring down the tone in these muscles that attach into it. So, the releases here are tensor fascia lata, gluteus medius, gluteus maximus. These are pretty easy to get to. They're pretty surface. The lumbar dorsal fascia on the opposite shoulder we'll review and get to, but don't forget it. And then you want to make sure that you've got the appropriate pliability in the vastus lateralis and the lateral part of the hamstring. How many of you are already doing that? Good for you! And you two, or three, are doing it, you just don't know that yet. Now you do. You know that, this is where you're going with this kind of stuff. So if we look at the medial side, there's a lot, isn't there? A lot happens on the medial side. Most of them have to do with stability. So in addition to tightening up the IT band or pulling tension onto the IT band, these same muscles are our AB ductors, counterbalanced by the AD ductors. And the AD ductors, am I saying that right?
AD, yeah.
Yeah. AD ductors are really bigger, aren't they? They're really bigger. So what do you think is more important? Adduction or abduction? So there's something about holding us towards our midline.
So you hear the occasion, so abduction out and away versus adduction. And the key thing being just visually look. Where is there more muscle? Is the IT band muscle? No. But all of the adductors are. So the lateral side of the leg has less muscle. The inside of the leg has more muscle. We'll tend to see more symptoms. So hip-based dysfunction, IT band, like the perception of the client is IT band's tight and their hip hurts. What's the other place I could look that would be associated with that?
On the adductors.
The adductors.
So come here, Luke Allen Fritz. I am going to be an adductor.
Right.
And you're going to be the abductor.
Mm-hmm.
Because there needs to be a communication now. Because if one is overpowering the balance, then you're going to either tip in, you're going to be knock-kneed like this, or you're gonna be unstable because your leg is pulled out. So, I'm an adductor, I'm big. He's an abductor, he's little. We're both gonna contract with about the same intensity. Who do you think's gonna win? Alright? So you belt yourself out. Who's working harder? Where do you think the symptom is gonna be? That's right. Who's the problem?
There was a good analogy of somebody, I think it might have been you, Laura, I can't remember, but somebody making the analogy that the victim will be screaming, but the criminal is somewhere else. So the alarm signal is over here, and now people will surprise you. But if we think in these agonist-antagonist relationships, which also tend to fit in, if there's something anterior, you should look at something posterior on the same portion of the body. If it's something lateral, you should look medial, and vice versa. Always looking in these agonist-antagonist relationships and seeing who is more of the problem. And it tends to be, in this case, who is winning the tug of war. And the body innately tends to follow a couple of key patterns where it tends to get too short, an exaggerated inflection and adduction. And you will feel symptoms in structures that go into extension or abduction. So think about all the muscles of the spine, for example. What are those if they concentrically contract? They're extensors. So bad in the leg, people with knee issues. The structures right here on in the anterior portion of the knee, those are extensors fighting the flexors.
Which are bigger.
The hip issues, hip problems tend to manifest on the lateral side of the leg. The symptom is there. A big part of this can be associated with the medial part of the thigh, the adductors. Same thing in the ankle. If there's issues with them spraining on one side of their ankle, you should go and look at the other side of the ankle. Or if they have shin splints in their shin muscles, I should look on the posterior side and look at the calf muscles. Isn't that a profound idea? It's why it fits with a good general full body, but it's about what you're thinking about. You're thinking very, very critically about doing something that feels very simple, or feels like just an overall full body, but I'm constantly asking that question and trying to follow these patterns. Specifically, one side of the body to the other, agonist, antagonist.
So if we look at the posterior side here, there's lots of tissue, isn't there? So there's a lot of activity attributed to this. Some of it certainly is stability. There needs to be a balance between your knee flexors and your knee extensors, but there's a lot more meat around the knee below the hip, distal to the hip, whereas all of the meat, primarily for the knee extension, is kind of in the middle. So when we're using an intervention now called inhibitory pressure, which means push on it without hurting it, where you are putting your pressure should recreate a symptom. At that point, we apply that pressure to that spot. Ta-da! Even better is to move the distal joint through its range.
So if I'm pushing on a muscle that functions at the knee, what movement should I have them do? Should have them move their
Flexion
knee.
and extension.
If I'm pushing on a muscle that extends the knee, I should have them extend it and flex it optimally. Depending on position on the table, I may only be able to do one or the other. Sideline lets you do both directions. versus prone and supine limits you because they are gonna end up pushing you to the table in one direction or the other. So, Logan's been stuck holding that for so long. So, in general, that it becomes, for your muscle edge techniques, you can just break it down to inhibitory pressure plus movement. But with muscle firing patterns or muscle activation sequences, it gets called either of those, then you can start thinking, how do the muscles that produce the movement all work together? So knee extensors, there's multiple of those, but how do they interrelate? So I may choose to push on one part of this muscle compartment versus another part. The tendency with the quadriceps muscles is the lateral aspect is a little too strong, and the medial aspect is not strong enough. Now, people might surprise you, but when we get to the firing pattern sequence, it ends up being I tend to apply inhibitory pressure on the lateral side of the quadriceps, have them move their knee into extension, trying to tell these muscles to shush. And since I'm not pushing on these medial muscles, they're being told you should work harder. What I push on, I'm telling to shush. What I'm not pushing on is gonna be forced to work harder. So
Now, you can do like, who's heard of trigger points? All right, you have to push on the precise spot, no you don't. All right?
what defines a trigger point?
They don't know.
Yeah. You push out and go, ow.
Yep.
Yeah, exactly.
They tend to line up where there's a neurovascular bundle, which means there's a nerve and a blood vessel, you know, like an artery and a vein and all that kind of stuff, kind of coming off the ones that go up and down and coming out to the surface. So, you're not talking to the muscle. You're talking to the nervous system. This is all about the nervous system, not about the muscle. So those of you that have been practicing for a while, who have you had come in and say, I have a problem with my hamstrings? You've had to have heard that.
They're tight.
My hamstrings are tight, or everybody likes to blame the levator scapula. My levator scapula is a problem. It's never the muscle. It's always the neurological interaction between these. So you gotta learn to talk to the pattern. Now, the exception to that rule would be if somebody had a specific injury to a soft tissue structure. Like they got, somebody hit them in a spot and the tissue was damaged. But in general, it's not about the muscle. It's about the neurological interaction.
Analogies I've used for this is like in sports or even other things that we repeatedly do to get better. Musical instruments can be one. You repeatedly do something until you get better at it. Your nervous system is hardwired to do that. The thing that you tell it to do more often, it gets more and more efficient at doing that thing. That can be a specific activity, like playing an instrument or doing a sports-based movement. It can be that you get really good at sitting. The nervous system can be trained to a new normal. And then we have to assume that that new normal is kind of hardwired in and try to train it back out. And we hope maybe we can find a nice balance between their compensation patterns based on what they repeatedly do and their comfort level. I want people to feel good in what they do and move and stand and breathe. But ultimately what we repeatedly do, our nervous system's gonna get really good at doing. So the nervous system's telling your muscles to shorten and lengthen in certain patterns and keep you either in that position or help you perform that specific action.
So what we've done in this first segment, I'm getting ready to break you
Right.
for lunch, and we're gonna have 45 minutes for lunch, is we've given you a generalized overview of the structures and how they work together. We've talked a little bit about how you would satisfy a client that is been told something different than is what is going on. We've talked about assessment and general massage being an important assessment. And giving you some ways of thinking that might be different. So, those of you that have been out in the world for a while, was there any thinking that you've shifted about? Like, oh, I'm gonna need to think about this differently than what, before we got started with all of this.
The ITN.
Okay, good.
That's a common one. I know for myself, cause I get regular massages now, I wasn't always as good about it. Because of my knee injury, I'm prone to, pain in my hip that goes down to my foot. So the more regular massages I get, the less pain I have.
Some sciatica.
Sciatica,
There we go.
I haven't had enough coffee today.
Yeah.
So people just want like an instant fix for the sciatica, and you have to explain,
And it
hey,
won't- it
this is
doesn't.
a multiple person problem. I'm not gonna be probably the only one that you may need to see. You may need to see your chiropractor. Don't think that you can come in one time and think I can fix it.
Well, and I'm
And
gonna
being-
tell you what, everything takes at least a year.
And being verbal with people and managing their expectations, letting them know that your first sessions are a lot about assessment. And as we've seen, and what we'll return to, is that it tends to be inhibitory pressure plus movement, and it can be, I'm thinking about helping this muscle function related to movement better. So if I'm thinking about knee extension and flexion, then I may put inhibitory pressure on structures that do that and have them move the knee into extension and flexion. But there can also be that whole just pushing on the spot to the point that it's satisfying, recreates the symptom, and you're looking then, and how do I change the nervous system's perception of how that area feels? And the one that's gonna be in the pamphlet, it deals with the whole position or release thing. And that's different than thinking specifically about a movement. That could be, I need to push on the spot and get the body to stop registering it in such a hypersensitive, alarm signal-based way. So an easy go-to, which we will return to, is you push on it and have them move their body in every way they possibly can until it is the most comfortable, and then they move back out of that. But you push on the spot, recreate the symptom, have them move until it hurts less, and then stare at them and try to figure out what their body's trying to tell you. Usually, they will shorten the tissue that you're pushing on, and that'll make it feel better, but that's not always the case. But those are two general good strategies. Push on a structure related to the movement, have them do the movement back and forth, push on the spot until it's satisfying, and have them move to where it doesn't hurt, and then move back out of that and say, how is it now?
Now, this afternoon, we're going to start by, right after lunch, learning about these firing sequences. That's the next place we're gonna go. After we get that done, and I don't have them all in there, only the ones that are relating to the lower limb. After that, what's gonna happen is my thal group. You're gonna go off with Logan and you're gonna practice a full body general massage thinking about this. Putting that, having that, all the stuff we talked about, all the awareness. Now, the big thing that limits people from working on the limb is that they're not comfortable working with clients in sideline. If you're gonna work on the lower limb and be efficient, you've gotta be confident with people on their side. So that's the big thing I want you to focus on with them. So we're gonna take 45 minutes, so about 5 after